you all to the Pediatric FSGS What Else Fails LDL Apheresis webinar. Just gonna remind you, this is an Opus medical design course for a maximum of 1 AMA PRA credit CME and a BIM MOC point. And the physician should claim only the credits commensurate with the extent of the participation in this activity. At the end of the webinar, we can answer your questions, so please enter them to the Q&A section. Right now, I have the pleasure to introduce Dr. Michael Moritz, which is a pediatric nephrology, pediatric professor of pediatric and clinical director of and medical director of pediatric dialysis at the University of Pittsburgh Children's Medical Center and associate researcher of clinical affairs. Thank you, Dr. Moritz, and you can start with the webinar.
All right, well, thank you so much for having me, and I want to thank all the participants for joining on at night to hear this, and hopefully I can share you some information you might find helpful in managing your patients. So the topic is pediatric FSGS, when all else fails, LDL apheresis. So the course objectives, after taking this, you should be able to know how LDL apheresis differs from therapeutic plasma exchange, how hyperlipidemia may be injurious in FSGS, and how LDL apheresis may be beneficial in the treatment of FSGS. So just to review, I mean, we all know this, but just to review about steroid-resistant nephrotic syndrome and FSGS, you know, idiopathic nephrotic syndrome is characterized by severe proteinuria, hypoalbuminemia, and edema. 15% of these patients will be steroid resistant. Of them, about 30 to 50% of them will be calcineurin inhibitor resistant. Most of them, but not all, will have a primary cause of a non-genetic cause of FSGS. Presumably, there is an undefined circulating factor that is assumed to be the cause, but that has not been proven. Multi-drug resistant nephrotic syndrome is defined as absence of remission in 12 months with 2 steroid-sparing agents, so calcineurin inhibitor, mycophenolic acid, one of the B-cell depleting therapies. There's more than one, possibly plasma cell depleting therapies, which are now being used. And if there is a multi-drug resistant FSGS, there is a 50% chance of end-stage kidney disease in 5 years. And of those patients, about 50% will recur in the transplant, and about 50% of them will lose their transplant. So what to do when you have a patient with multi-drug resistant FSGS and you know, it's multi-drug resistant? What do you do then? What happens if you have a person with recurrent FSGS post-transplant and they're unresponsive to therapeutic plasma exchange? What do you do if you have a person who has recurrent FSGS post-transplant and they're on therapeutic plasma exchange, but you can't wean them off? When you decrease the frequency of therapy, the proteinuria increases. And I've encountered all of those, and I've used LDL apheresis for all of those cases, and I will share that with you at the end. So in terms of LDL apheresis, you know, what is it? How does LDL apheresis differ from therapeutic plasma exchange? We'll talk about that. We'll talk about how it works. I'll present you some clinical studies with LDL apheresis and FSGS in both pediatrics and adults, and then our Children's Hospital of Pittsburgh experience. You know, early on in my career, we would use therapeutic plasma exchange, plasma apheresis for recurrent FSGS, and we had fairly good experiences, and we published those results. But unfortunately, it doesn't work for everybody. And it was very intriguing when LDL apheresis was available in the United States, and I was one of the early adopters of that. So what is therapeutic plasma exchange and what is LDL apheresis? Well, therapeutic plasma exchange is the extracorporeal removal of plasma. There's two different machines you can use. There's centrifugation or membrane filters, and that removes proteins non-selectively. So it removes large molecules, LDL, and also HDL in equal quantities. It also removes antibodies. And when you do plasmapheresis, you can either replace with colloid, either 5% albumin or FFP. So when you write for plasmapheresis or plasma exchange, you have to call the pheresis people or calculate how much 5% albumin to give, how much FFP to give. You have to have it called up at the bedside. It's a little bit more cumbersome. And then there's either 1 to 1.5 plasma volume of plasma exchange. That's typically 30 to 40 mLs per kilo. It's a 2 to 3 hour therapy. And then there's citrate anticoagulation, which is a little bit complicated because you have to order calcium. You have to reverse the citrate. The patient can become hypocalcemic. Even if they don't become hypocalcemic, they can get sick with the citrate and they can, have nausea and vomiting. So it's not the most pleasant experience for the patient. So there are many indications for therapeutic plasma exchange. There's numerous neurological conditions it can be used for: Guillain-Barré, demyelinating polyneuropathy, myasthenia gravis, pandus. For hematological conditions, TTP, aHUS, paraproteinemia, cryoglobulinemia. For renal conditions, which we're familiar with, anti-GBM disease, good pastures, a severe ANCA, rapidly progressive glomerulonephritis, recurrent FSGS in the transplant, antibody-mediated rejection, and metabolic causes, familial hypercholesterolemia, and Wilson's disease. So these are all the reasons for therapeutic plasma exchange. The reason why I have recurrent FSGS in bold and familial hypercholesterolemia in bold is those are the two indications for LDL apheresis. So therapeutic plasma exchange is indicated for some of the same reason. LDL apheresis, I should say, is indicated for the same reasons as therapeutic plasma exchange. So therapeutic plasma exchange can be helpful in recurrent FSGS and can be helpful in familial hypercholesterolemia. So lipoprotein apheresis is a little bit different. It selectively removes the ApoB containing lipoproteins, which have LDL, VLDL, and lipoprotein A bound to it, more so than HDL. It does not move HDL so much. The system that is available is the Liposorber LA15 system by Kaneka. And we're going to show this, there's different cartridges. There's a plasma separator. So plasma is separated, and then the plasma goes through 2 dextrans sulfate columns, which remove the lipoproteins. The plasma is then recombined with the blood cells. And it's sort of interesting how the columns are regenerated to remove more lipoprotein. A nice thing about LDL apheresis is you get to use heparin anticoagulation versus citrate anticoagulation. So that's much simpler. You do not have to, write for citrate. It's still 2 to 4 hours. And you also do not need any 5% albumin or FFP. You just need to write for standard crystalloid. It's not a proprietary crystalloid made by Kaneka. It's just a crystalloid which is used to regenerate the fluid. It's 1.5 plasma volumes, and there's about an 80% acute reduction in the LDL cholesterol and a small reduction in HDL. So this is the apheresis. This is the LDL apheresis machine. Let me turn my pointer on, which I forgot to do. So this is the plasma separator column. These are the absorption columns that remove the LDL, and this is the tubing. And so this is sort of how it goes. The blood is circulated through the plasma separator. So this separates the plasma. Now the plasma goes through the Liposorber cartridge, and that absorbs the fat. After about 6 mLs, the cartridge is saturated, and the machine automatically switches it to another cartridge, and then that cartridge is flushed with crystalloid, removes the protein and regenerates it, and this goes back and forth until the treatment is done. The plasma is then returned to the patient. So that's how it works. And how do these absorption filters work? So they have these beads that have negatively charged dextran sulfate. So you can see these beads have dextran sulfate all the way along, and these are negatively charged. And ApoB, which has the VLDL, lipoprotein A, and LDL, are positively charged, and they bind to the dextran sulfate. Now, HDL has ApoA, which does not bind that well to the dextran sulfate. So that is how it removes the fat, and then it gets regenerated. So the main historically, the main indications for LDL apheresis was familial hypercholesterolemia, where diet or drug therapy is ineffective. So homozygous familial hypercholesterolemia with the LDL cholesterol greater than 500, heterozygous with the LDL greater than 300, heterozygous with LDL greater than 160, plus coronary artery disease. So how does hyperlipidemia affect nephrotic syndrome? Well, nephrotic syndrome promotes lipoprotein synthesis, and it leads to hyperlipidemia. Now, the hyperlipidemia, the oxidized LDL is incorporated in mesangial cells and in the macrophages. And when that happens, you get overexpression of inflammatory cytokines. So it causes an inflammatory state. So you can see this on a kidney biopsy. You can see vacuolization of the tubules. You can see foamy macrophages. If you look in their urine, you can see, lipiduria. Sometimes you can see histiocytes, which are like macrophages, which are loaded with lipid droplets. You can see this under urine microscopy. The oxidized LDL also goes into the blood vessels and causes endothelial dysfunction. And the nephrotic syndrome leads to a hypercoagulable state with elevated fibrinogen and thromboxane A2. It leads to platelet hyperactivity and hyperaggrability, so which is the hypercoagulable state. So how is it that LDL apheresis was used for FSGS? Like, where did this come from? Well, it's my understanding is it sort of came by accident. And the first patient to get LDL apheresis was a 16-year-old female in severe renal failure. So this is the first report of LDL apheresis being used for FSGS. They reported on 5 patients aged 16 to 54. In the study, they alternated LDL apheresis with therapeutic plasma exchange, and they had about an 80% response rate. So patient HS was the first patient. It's a 16-year-old female, massive proteinuria, had nephrotic syndrome for 9 months, had a very high cholesterol, had FSGS, and failed steroids, immunosuppressants, anticoagulants, antiplatelet therapy. And very interestingly, she had severe renal failure. Her GFR was 14.8 milliliters per minute. And they used the therapy because of the hypercholesterolemia. And miracle of miracles, her GFR improved, renal blood flow increased significantly, and her proteinuria went from 20 to 30 grams a day to 1.5 to 2 grams a day. And you can see that the other patients had very similar responses. So this is this young girl who received the LDL apheresis. And as soon as the apheresis was starting, you can see her creatinine improved and her proteinuria went down from a protein creatinine ratio of 20 down to a protein to creatinine ratio of about 1 or 2. So, well, how did that work? So there's different hypotheses for how LDL apheresis could work. It could be a direct effect of the lipid absorption. So reduction of macrophage stimulation ameliorates macrophage dysfunction, decreases inflammatory cytokines. So when we use calcineurin inhibitors, this is what we're trying to do, cytokine inhibition. And now it's been more recently showed that not only does it reduce inflammatory cytokines, but it upregulates anti-inflammatory cytokines, so cytokine IL-10. It has vasodilatory properties by increasing nitric oxide, vascular endothelial growth factor, bradykinin, decreases thromboxane A2, decreases blood viscosity, and possibly removal of a permeability factor. If the permeability factor is a high molecular weight protein, then it could be removing it. But what I think is the main mechanism is it improves intracellular drug transport. What you're going to see in the next slides is that somehow LDL apheresis converts a patient from being steroid resistant or multi-drug resistant to being steroid responsive or multi-drug responsive. And that conversion is permanent and not temporary, which is very interesting. So these are the clinical studies done prior to 2017. Some are done in children, some are done in adults. They're not just in FSGS. They're in a variety of glomerular diseases, FSGS and minimal change disease, IgA, membranous nephropathy. These are patients who are resistant to therapy. Most of the studies did twice a week LDL apheresis for 3 weeks, followed by weekly apheresis. Not everybody did the same amount of therapy. They all used steroids in conjunction with it. And there was approximately a 60 to 75% response to the therapy of a partial or complete remission, and it was durable. So following that data, there was the large Polaris study by Musso. He's really done the most work in this field. And this was a prospective observational survey on the long-term effects of LDL apheresis on multi-drug resistant nephrotic syndrome. It was a multi-center study in Japan. Patients had to be steroid resistant from at least 4 weeks of therapy. They enrolled patients over 2 years with at least 2 years follow-up. And the amount of LDL apheresis and the immunosuppression was left at the discretion of the treating centers. So there wasn't a specific protocol per se, and the average amount of LDL apheresis sessions was between 9 and 10. 44 patients were enrolled that had complete data. You can see that on the short term, this is a short term, the protein creatinine ratio, the urinary protein decreased by about half. The cholesterol decreased significantly by about half. And the thrombotic factors decreased. So if you look at it in terms of the different diseases, very interesting, it worked for both FSGS and non-FSGS. So FSGS in the short term, the proteinuria decreased by about half, and that was about the same for non-FSGS patients. Now, interestingly, the group that it worked least well on, no, there's only 2 patients, was minimal change disease. So interestingly, long-term, the proteinuria continued to go down. And the short-term response was the most predictive of a long-term response. So long-term, 75% of the patients had a response. About a quarter of the patients did not have a response. Their urine protein was greater than 3.5 grams. 25% had an incomplete response, where the proteinuria is between 1 and 3.5 grams. Incomplete response 1 was between less than a gram, and a complete remission was, normal amount of proteinuria. So about 75% response rate. So this is the pediatric study by Hattori, and they looked at patients who had, again, cyclosporin resistant FSGS. Patients had to have failed 8 weeks of prednisone plus 12 weeks, at least 12 weeks of cyclosporin and prednisone. They all had to have nephrotic syndrome at the end of that period, serum albumin less than 2 with nephrotic range proteinuria. They enrolled 11 children over 7 years. The median age was 12. They had a disease duration of approximately 2 years. They had significant proteinuria, almost 10 grams per meter squared per day, and hypoalbuminemia. So take a moment to digest this slide if you don't know anything about LDL apheresis, if you've never done it before, just digest this slide a little bit, because this is going to be the most important slide if you're thinking about doing it. So it starts off with 2 sessions a week for 3 weeks. And during that period of time, you do not give additional immunosuppressive therapy. After this sort of what I'm calling the induction period, then you go to weekly for 6 weeks and you give steroids. So this is a must. This really is a must do. Somehow this therapy converts someone from being steroid resistant to steroid responsive. And I would also add that it's not just LDL apheresis that does that. When you give it B-cell depleting therapy or some other therapy, just because someone was steroid resistant initially doesn't mean they will be steroid resistant when you add other drugs. But this is particularly the case with LDL apheresis. And then the steroids are tapered. So during that first 3 weeks, nothing happens with the proteinuria. But as soon as the steroids are started, you start seeing an improvement in proteinuria. And interestingly, it continues after the LDL apheresis is discontinued. And the most predictive response is if they have an early response, it's going to be durable. So the patients who responded had preserved GFR. Those that didn't went on to develop renal failure. So based on this information, based on this data, LDL apheresis was FDA approved in children in the United States in October 2013. So it was approved on a humanitarian device exemption for pediatric patients with nephrotic syndrome associated with FSGS. So standard treatment had, so if you're not a transplant patient, standard treatment had to be unsuccessful and the GFR has to be greater than 60, despite the fact that the first slide I showed you, the first person who had ever used on had a GFR much lower than that. So that is the inclusion criteria. Now for a post-transplant, or it can be used in a post-transplant patient, and for that, you don't have to have a GFR requirement. The protocol is the Hattori protocol, 12 sessions over 9 weeks. So twice weekly for the first 3 weeks and weekly thereafter for 4 to 9 weeks. So just for comparison, if you're doing plasma pheresis or plasma exchange and you want the best results, you pretty much have to do it 3 to 4 times a week indefinitely until you start seeing a response. And then you start tapering the therapy, and then you just continue to taper. So it's a lot more intensive than this therapy. So in terms of ease, this is much easier for the patient than therapeutic plasma exchange. I would also want to point out, though, even though you can do it in this country and you can get it paid for, it does require an IRB, and you have to have a consent form. And depending on your institution, there may be a fee associated with getting that IRB. And at our institution, there's a hefty cost associated with it. So this is a report. So there's been 2 pediatric reports on its use after that FDA approval. One was by the group in South Carolina, and they used it for patients with resistant nephrotic syndrome. So none of these patients are post-transplant. And you can see, even though the approval is for FSGS, they used it in FSGS patients and minimal change disease patients. They had basically been treated with everything, steroids, calcineurin inhibitors, tacrolimus, cyclosporin, different B-cell depleting therapies, rituximab, ofatumumab, CellCept. They got the kitchen sink thrown at them. And this particular patient here had the worst disease. So 33% global sclerosis, 8% segmental sclerosis, and then this patient had severe interstitial fibrosis. So the likelihood of responding wasn't good, and this patient did not respond, which you'll see on the next slide. So that's patient 3. Keep that in mind, patient 3. So everybody but patient 3 responded. Here's the urine protein to creatinine ratio, and you can see that the proteinuria continued to fall long after the LDL apheresis stopped. This patient was unresponsive to therapy, and patient 4, who was also the FSGS patient, responded and then relapsed. But we do not have, the paper does not give any follow-up on how they treated the relapse and what happened. So we don't have follow-up on that. This paper by Zaritsky's group, this was LDL apheresis for recurrent FSGS in the transplant. There were 2 centers in the United States, 2 centers in the UK. They enrolled 7 patients who had immediate or early recurrence. All the patients had received tacrolimus, mycophenolic acid, rituximab, and failed plasmapheresis. Once they got LDL apheresis, they did things a little bit differently. They gave pulse methylprednisolone in addition to the standard protocol of steroids, and they all achieved a partial or complete remission. So this was their ages. They were ranging between ages of 4 to 10. The duration post-transplant was anywhere between 1 week and 18 months. They had all failed 3 times a week plasma pheresis, and the amount of LDL pheresis varied. And when you sort of see the patients that I treated, you'll see why. Sometimes you just don't feel that 9 weeks was enough, and it's sort of hard to stop it. And you think, well, if 9 weeks is good, maybe more is better. So in certain cases, they continue to pass the 9 weeks. And this is the results of their patients. This is the LDL apheresis, and you can tell that even after the LDL apheresis stopped, there's a further reduction. In many of the patients, there's a further reduction in proteinuria. And in all of them, the reduction in proteinuria was durable. So we started doing it as pretty much as soon as we could. Our rate limit, this company was great. Our rate limiting step was getting the IRB approval. As soon as we got the IRB approval, we started doing it. And we've done it in 6 patients. We've done it in 2 patients with multi-drug resistant nephrotic syndrome. We've done it in 4 patients with recurrent FSGS post-transplant. Each of them had a different clinical presentation. So I'm going to present each patient separately. We're in the process of writing this up, so I'm not going to give a ton of detail. So patient number 1, this is a patient with multi-drug resistant nephrotic syndrome. It's a 5-year-old female who had minimal change disease, but she failed to respond to 6 months of steroids, MMF, Prograf. Her albumin was 1.3. Her urine protein creatinine was 8. She had significant edema. So we tried LDL apheresis, and we used it for 21 weeks because it seemed that as long as we continued it, her proteinuria continued to improve. So she got LDL apheresis plus steroids. We did use the pulse steroids as Zaritsky did with MMF and with Prograf. And she has had a complete remission for 7 years post LDL apheresis. She has not had any relapses, and she's on very low dose FK. And you may want to say, well, why don't you just stop the FK? Because the family is scared to death of her relapsing. So we've been very slow in tapering the therapy. But 7 years, no relapse. So patient 2 is a patient who had late multi-drug resistant nephrotic syndrome. It's a 15-year-old male who had C1q nephropathy on biopsy. He presented at 6 years of age and was initially steroid responsive, but then he became late multi-drug resistant by the age of 15. He had been treated with prednisone, Cytoxan, MMF, FK, B-cell depleting therapy 5 times, and he could not get into a complete remission. His albumin was 1.5. The urine protein to creatinine ratio wasn't too bad. It was 1.5. He received the conventional Hattori protocol, 9 weeks of LDL apheresis plus steroids, MMF, and FK, and he went into remission. But he relapsed at 6 months, was treated with B-cell depleting therapy, stayed in remission off all therapy. And the reason why I say off all therapy, because as soon as he went into remission, he stopped taking all his meds. So you couldn't even keep him on anything. And then at 2.5 years post LDL apheresis, he relapsed again, got treated again with steroids and B-cell depleting therapy, went into remission again, and he's been in remission off therapy for 5 years post LDL apheresis. So this is actually the first person we treated. This was a young girl who had recurrent FSGS post-transplant, and she was plasma exchange dependent. So it's a 6-year-old female with steroid-resistant FSGS. She had a preemptive living unrelated donor transplant. She had an early occurrence, not an immediate recurrence. She recurred within a few weeks, not a few days post-transplant. Her albumin was 2, urine protein creatinine was 5, serum creatinine 0.6. It took her 4 months of plasma pheresis to achieve a remission, and then we started tapering the plasma pheresis. On weekly plasma pheresis, her protein creatinine ratio was 0.5, which we were satisfied with. But when we went to every other week plasma exchange, her urine protein creatinine ratio went to 1.5. So she had been on plasma exchange for a year, and we couldn't get her off of it. We used LDL apheresis. Now, because she was in a partial remission and her serum albumin was good, we did not give her steroids. And that may have been my ignorance, but I didn't give her steroids. And she came off therapy with a complete remission without any proteinuria. And it's our first patient. So she has been relapse-free for 8 years post-therapy with a good GFR. Patient 4 had immediate recurrence of FSGS post-transplant, and she was refractory to plasma exchange. So a 5-year-old female with end-stage kidney disease on dialysis, secondary to steroid-resistant FSGS. She had a deceased donor transplant. She had an immediate recurrence with severe, massive proteinuria, urine protein to creatinine ratio 286. We biopsied early, and she already had FSGS on biopsy. She was unresponsive to 3 months of plasma exchange. We did 4 times a week for 1 month, 3 times a week for 2 months, and there was really no response. Her albumin was 1.8. Urine protein to creatinine ratio was 100. She was going into renal failure. Her creatinine was 1.3. So we did a 9-week course of LDL apheresis with steroids, FK, Imuran, and an ARB, and it sort of helped. I mean, her protein creatinine ratio went from 100 to 18. Albumin was still 1.8, so not a great response. So we treated her with another course of LDL apheresis with pulsatile umedrol, prednisone, and B-cell depleting therapy. And she had a complete remission for 7 years post LDL apheresis. But interestingly, she has had a relapse every single year, and she responds to either steroids or B-cell depletion. So she has normal GFR, complete remission of proteinuria, but she continues to relapse. But it converted her from a steroid resistant to a steroid responsive. Now, this doesn't work for everybody. I wish I could say it's 100% successful, but it's not. This person unfortunately failed therapeutic plasma exchange and LDL apheresis. Was a 4-year-old boy with end-stage kidney disease from steroid-resistant FSGS. Genetics were negative. All the patients had genetics that were negative. Had a living donor transplant, immediate recurrence, unresponsive to 8 weeks of plasmapheresis. Serum albumin was 2.8. Urine protein to creatinine ratio was 20. Had 9 weeks of LDL apheresis, no response. Received another week of LDL apheresis with pulse steroids, B-cell depleting therapy. Had no response. Returned to dialysis 1 year post-transplant. And he continues to be, unfortunately, dialysis dependent. And this is our last patient. So after those experiences, we're like, okay, enough with this therapeutic plasma exchange. If we have another patient with this, we're going straight to LDL apheresis. This is an 18-year-old male with end-stage kidney disease, dialysis dependent. His genetics had autosomal recessive Alports. We didn't think he was going to recur in the transplant. He had a deceased donor transplant. Interestingly, he did not have an early recurrence. His recurrence, he recurred at 3 months of age. By raising his immunosuppression, he seemed to go into remission. Then at 6 months, 6 months post-transplant, he was in a full-blown relapse. On biopsy, there were 33% of the glomeruli had focal sclerosis. So that's pretty severe. Albumin was 2.4, urine protein creatinine was 9, serum creatinine was 1.4. He received 9 weeks of LDL apheresis with steroids and B-cell depleting therapy, and he's been in remission for 2.5 years post-LDL apheresis without a relapse, with a pretty good serum creatinine. So in conclusion, LDL apheresis seems to be effective about 50 to 75% of the time in patients with steroid-resistant nephrotic syndrome. The short-term response results in a favorable long-term outcome. If they do well short-term, they're going to have some type of durable response. It appears to be more effective when combined with other immunosuppressive medications. So we and others treat more than the Hattori protocol of just steroids. And there's numerous plausible mechanisms to explain the efficacy of LDL apheresis, whether it decreases lipid nephrotoxicity, vasodilation, decreased hypercoagulability. But what it seems to do is it seems to improve the immunosuppressive responsiveness. It converts them from a multi-drug resistant to either a steroid responsive or multi-drug responsive apheresis. And we will stop there and take any questions you might have.
Thank you, Dr. Moritz. That was a fantastic presentation. lot of things to do with all these patients with the recurrence of FSGS, so resistant nephrotic syndrome. We have one question from the audience right now. Does the level of LDL matter?
No, it doesn't. So
Okay.
even if you, so that's a good question. So the patient we had who was TPE dependent, she did not have hyperlipidemia. So many of these patients, remember, they were on plasma exchange, and plasma exchange does remove the LDL. So no, hyperlipidemia is not a requirement. And I will elaborate further on that. I didn't put this in there, but we've used you're like, well, why would you even use LDL apheresis now that we have PCSK9 inhibitors? PCSK9 inhibitors, they drop the LDL almost as much. They have not. There are some reports of PCSK9 inhibitors being effective, but we've tried it and it has not. It's not as effective as this. So there's something independent of just lowering the cholesterol. I'm not saying it's a circulating factor, but it does something else.
Okay, thank you. I do have a few questions on my own. When you decide to start LDL apheresis, do you stop plasma apheresis right away? Do you wean them off? Or there is a period of...
We stop it right away.
Okay. So it doesn't matter, let's say it's a Monday, they have plasma apheresis, and Wednesday they can start LDL apheresis, something like that.
Right. Yes. Right. You can do that. And again, it's so with the problem with plasma apheresis. So generally speaking, when we do plasma apheresis, we don't do plasma exchange. We replace with 5% albumin, not with FFP. And when you do that, your patient can be anticoagulated. So you can't do the therapy so intense. The nice thing about switching over to LDL apheresis, you don't have to worry about any of that. It doesn't remove the patient does not become anticoagulated by removing the clotting factors. So it doesn't affect the PT-PTT. You can just switch right over.
Okay, thank you. There are some more questions for the audience. What's the experience with adults with recurrent FSGS post-transplant? You mentioned one 18-year-old patient, but do you have any experience in the adult world?
I think it's a good question. I think it's about the same. The numbers are small. But now that you're asking me, I'm trying to see, was there a specific report? I believe in adults, it's about, all the studies are fairly consistent, about 50 to 75% response rate.
They are recruiting adult patients for the trial because the FDA is asking for adult information on this therapy as well. But I haven't seen the results yet.
There is a report on a few patients who they did LDL apheresis, and that's usually we don't have a dialysis catheter, but there are some reports of doing LDL apheresis prior to transplant with good results. But these are small numbers, and whether it makes a difference or not, again, with small numbers, you can't really tell.
Okay. Another question here is, have you used LDL apheresis in patients who have partial response, but seems to be immunosuppression dependent?
Like
a partial response?
Not in pre-transplant patients, no.
Okay.
Only because putting in a apheresis catheter, and doing it, we sort of really reserve it when all else fails. So we haven't done that. If someone had a partial response and they hadn't had an edema, we just haven't. That doesn't mean you couldn't, but the cases that I show you that's all the experience I have. That's what I have.
Okay.
I've not done that.
Okay. I have another question. When you start the steroids, so after the induction phase, you go to basically the maintenance phase. When you start the steroids, do you keep them in 1 milligram per kilo for 6 weeks, or you start taper for 1 or 2 weeks and they start tapering?
So we do just like you would with a new nephrotic. Well, I don't know what you do with the new nephrotic, but if you treated a new nephrotic with ISKD, per protocol, you would do steroids daily for 4 weeks, even if they went into remission for 1 week. Though I know there's papers that have just come out that you don't really have to do that. You can taper quickly, but no, we would do the steroids for the full month and then taper. Under the belief that somehow it's the steroids that induces the remission, but usually they're going to need it for these patients are so severe, they don't typically respond quite as fast as a minimal change disease patient who's going to have no proteinuria in 2 weeks.
Yeah.
Like, we haven't had that happen.
Okay, I'm asking because after transplant, they're in standard immunosuppression, and if you're gonna start LDA apheresis, everyone is afraid of extra doses of steroids, but for sure, 1 milligram per kilo, and the maintenance phase is best that bolus of steroids and start with the high doses from the beginning.
Yeah, it's a good question. In pediatrics, kids tolerate steroids better than adults do. So we're a little bit lucky in that regard. I know, steroids in adults can be a lot worse.
Yeah. Okay. There are some comments and questions regarding FDA approval for post-transplant patients with recurrent FSGS. What is the cost for each treatment, and if the insurance paying for that? How is your experience on that end?
So the getting it paid for it is not a problem, and I'll have to let Kaneka talk about it, but getting the machine from Kaneka, that's real easy. But they're great about that. And we have at our institution, every center is different. At our institution, the people who do plasma pheresis also do the LDL apheresis. Now, I don't know. I can't tell who on the line is from the adult or whatnot, but this is used in adults. Like, LDL apheresis has been used for hyperlipidemia, so you may have it. You may have it in your institution, already. And if they're an adult patient, I'm not sure that you need an IR.
Oh, I think we lost him. We're gonna wait a few minutes to see if he can connect again. But what he was saying, that it's being used in adult population with recurrence of FSGS. I personally am trying to start using in my center, and we are been working with the plasma pheresis team in order to be trained and obtain the machine. But that's as far as my experience goes. Still trying to get, due to institutional issues, not due to any industry issues. Okay. Okay. Regarding the payment, the guidelines for the American Society of Apheresis has a specific section that explain how do you bill for this treatment with the specific cause diagnosis, and it's a very well explanatory way to bill. So you may need pre-authorization for the insurance, but it's an available therapy in all these resistant cases that 99% of the time you don't even need to do a peer review to get approval. Okay. Let me see if we have another comments. Yes. Soon to come to our institution. Yes, that's good. Does LDL apheresis affect drug levels? And which one is so? As far as I understand, no. Not that I recall. Okay. There's one question of how do I initiate the process? Who I need to contact? You can get in contact with the company directly, and I'm sure they can reach out to you. Dr. Moritz is back.
Hello, I don't know if you can see me. My computer decided that it wanted to update its software. So if everyone's gone, very sorry.
No, don't worry, don't worry. I think I answered all the questions so far. I have one question that I don't know if I'm 100% sure, because they say, does LDA apheresis affect drug levels, and which one if so? As far as I remember, there was no issues. But
that's a really good question. No issues. It just, yeah, it removes very large molecules. It does not affect drug levels.
Okay. So
those are great questions.
Yeah. More people are just asking how to, we connect to get the process started, and I'm so sure that they can connect directly.
I don't want to get Kaneka upset. I can only tell you what Kaneka did with us. But if I remember correctly, they gave us the machine, or at least we didn't have to buy the machine from them, just the cartridges, and we never had a problem getting it approved by insurance. And it wasn't difficult to make the change from for the nurses who do the therapy, to make the change from plasmapheresis to LDL pheresis was not a problem. And also, again, I can't speak for Kaneka, and I can tell our experience, because we don't do, like, we could go years without doing a therapy and then do a therapy because we haven't done it for a while. Kaneka always comes and they show up, and they're there and they're standing there doing it, because I haven't written the order for like years. I haven't done it for a while, and they really helped us. And it was easy, and it's always gone well. We haven't had any problems. But usually when we start a new therapy, if we haven't done it for a while, they come there to the institution and make sure everything's done correctly.
Okay.
But I can't speak on their behalf. That's just been maybe they like me. That's been my
experience. Your experience with them, which is great.
Yeah.
Yeah. All right. There is another question. I think it will be the last one. If this is FDA approved, why does it need IRB approval?
So that is a really good question, and I almost made a major screw up. So I knew that when it was approved in 2013, I knew it needed an FDA, and I knew it needed an IRB. And I got the IRB, and then I believe in 2021 or 2022, it was renewed. And I said, well, what's renewed now? I don't need the IRB. So, and then when I met Kaneka in the meeting and I told them I didn't renew the IRB, they were like, oh, no. Even though the FDA renewed it again, it's still investigational, and they want the IRB. So I don't know. I sort of think it's a bit ridiculous, because IRB is not, it's a pain. I mean, I don't know. It depends on your institution, how much support you have, but it can be difficult submitting something, through an IRB, and it can be costly, and it has to be renewed. Yeah. So that's a little bit of a pain.
Exactly. Yeah. Well, those are the regulations we have to follow until the FDA fully approve after the upcoming study. Okay. I would like to thank everyone for attending, and would like to thank Dr. Moritz for being so eloquent and fantastic about the presentation and answer all our questions. I know that we put this slide to get the CME early on.
I'm sorry that my slides dropped off.
Don't worry. But you can get online to Opus Medicus and claim your CME credits. Thank you, everyone. Have a good night.
Thank you, everybody.
Bye. Thank you. Bye-bye.